Welcome to my podcast, The Lower Down Experience. Many of you will know me from my Instagram page, @FabulousPharmacist, where I love to shine a light on topics that people normally shy away from. Today I spoke to Dr. Phil Kieran. Dr. Phil is a GP in Cork. We discussed all things male health this episode. We touched on topics such as erectile dysfunction, hair loss, fertility, mental health, grief, the male menopause. If you are a man, or if indeed you have a man in your life, you will find this podcast super interesting. To support the Lower Down Experience, please check out my sponsors in the podcast notes below. Enjoy the show. So Ireland's very own Dr. Phil. Welcome to the podcast. It's a pleasure to have you.
I'm never going to escape that.
No, you won't.
I might. No. Thank you for having me on, Laura. It's great.
It's wonderful actually, because I wanted to speak to a male doctor about male issues, because I had many people message me and say they really wanted someone like yourself on. And when I put it out to people, the main thing that came up was erectile dysfunction and people's worries and concerns around that. So can we speak about that?
Yeah.
And, in a really candid way, because even though we have Viagra, sildenafil, tadalafil, all of those things, I think it's still quite a taboo subject. And certainly for younger men, which we're seeing more and more of people presenting with erectile dysfunction. So erectile dysfunction is a topic that I love to talk about because people don't like to talk about it. And it's one of these things that, so firstly, what I always say to my patients is really common, right? Okay, so people think about it as, that's something that happens to other people. But 55% of men over the age of 40 will have an experience of erectile dysfunction. Now, whether it's very short-lived or whether it's a persistent problem, it's really common. That's more than half. So it's you could nearly say it's more normal to have had some issues with erectile dysfunction than not to. Okay.
And I think no one talks about it. Still no one talks about it. I've taken to my own practice, I've taken to asking people specifically about it at the end of their consultations. Because a lot of the times when people did finally talk to me about it, they told me that they'd made 3 or 4 attempts to talk to me about it and then had chickened out of it,
It's terrible, isn't it, that they're under that? Because I think that they're under pressure first and foremost.
Yeah.
And then also it is an embarrassing issue to say, my penis isn't working in the way that society thinks I should, or that I want it to, obviously. And then, off those people that you say it to, are they shocked sometimes that they're not expecting the question?
They sometimes are, sometimes they're not, and which makes me think that, the previous 15 minutes of chat that we had probably wasn't the main issue they wanted to discuss in the consultation. But I think when I tell them how common it is, it does catch them all by surprise, and it makes them a bit more open to talking about it. I usually follow that up with, now I'm going to ask you some very blunt questions, because I don't think there's any way to talk about this without just being blunt about it, So particularly when people start talking about it, I think people would understand that they have erectile dysfunction if they get no erections, right? If they can't have an erection at all, I think most people would say, I have erectile dysfunction. But the people who have short-lived erections or softer erections than they would like, that's erectile dysfunction as well. And I think a lot of people, think that they should just shut up and not complain about it. And B, then they're too embarrassed to talk to their doctor about the details of their penis.
Yeah, I know. Yeah.
Which is I talk to people about their penises all week long. It's a large part of my job in a practice where I'm a male GP and there are female GPs. I do an awful lot of penis medicine. Well,
and I think that males probably feel more comfortable going to a male about an issue like that maybe because, I know certainly as a female, I feel more comfortable going to a female doctor about my gynecological issues or concerns, and it might just be that, but...
It could be, and also, if you're seeing someone of the same sex as you, then at least you can finish your sentences with "and so it's an easier conversation.
Absolutely. And what are the reasons why a man might have erectile dysfunction?
So there's lots and lots of reasons. Okay, I think what a lot of younger men particularly are worried about is that they'll be told that it's all in their head, but pure psychological erectile dysfunction is actually only about 10% of cases.
As in performance worry or something like that?
Performance anxiety, yeah.
Okay.
And it being that alone and nothing else is only about 10% of cases. So I think if you do have a concern about erections, it's really important to go and talk to your GP, because not only will they be able to give you help with the erectile dysfunction, but also it's important to get screened for any underlying problems that could be contributing to it. So the big ones really that we would always screen for would be undiagnosed diabetes, untreated blood pressure problems or low testosterone levels.
Okay.
And then sort of less common than that, you'd have problems with thyroid function or low iron levels. And a lot of the times, if you find that there is an issue in one of those things and you fix it, the erectile dysfunction goes away.
That's mad. And how does undiagnosed diabetes affect erections?
So undiagnosed diabetes, or diabetes in general, causes damage to blood vessels, right? And so one of the big things that we worry about, and the reason we treat diabetes, is to prevent people getting heart attacks and strokes and things like that. Now, they're big blood vessels. Erections work by blood flowing into your penis through very small arteries and then not flowing out as easily. And so it gathers in the penis under pressure, and that's what causes the erection to happen. So if you are damaging those blood vessels, or if the nerve function is being hampered, which can happen in untreated diabetes as well, that can cause erectile dysfunction. And erectile dysfunction, in some cases, can be the earliest sign of diabetes.
Okay,
so it's important to get that checked out. A lot of the times it's not that.
Yeah.
I just don't want people to go, well, I don't want to find out I have diabetes.
As well as
erectile dysfunction. But it does mean that a lot of the times if you get that under control, the erectile dysfunction goes back to normal.
Okay.
Or disappears, I guess.
Okay. And then with blood pressure issues as well, that makes sense, obviously, with the blood vessels.
Same thing with blood vessels.
And then purely from the psychological point of view, if you're seeing are you seeing younger men with erectile dysfunction issues, or is it that we don't have the data from years ago? You know, is porn causing a huge problem with these men?
It is. I suppose it's difficult to know whether it's causing a bigger problem now, because I think if you try to go find data on porn usage in Ireland in the 80s, it might be a fairly short read.
The odd magazine.
That existed somewhere in the village, but no one ever looked at it.
No.
So we are definitely seeing a lot more younger people with erectile dysfunction. Now, I think that's probably a combination of people being more open to talking about it and knowing that there is something you can do about it. But is there an increase going on in it? Maybe. What I am seeing a lot of an increase in, which would be more closely linked to porn consumption and stuff, is premature ejaculation and performance anxiety.
Okay.
So there are a lot of young people, because in Ireland we have a woefully poor sexual education program, because no one wants to talk about that.
No.
People get a lot of their information about sexual relationships from watching porn.
Yeah.
Do you know, which is ridiculous. It is nothing representative of relationships.
But should they say apparently a young boy will access porn before he'll have seen hardcore porn, but before he'll even have kissed a girl at this stage, you know. That's what's actually happening because of phone. You know, they've access to their phones,
the internet's in your pocket.
And even if a parent has, you know, access to control over the child's phone, there's always going to be one kid in the class. And you know yourself, when you're growing up, there was always one kid you were hanging around with that had that video, that video cassette,
the video cassette
that they found in their dad's
traded around. Yeah.
So it's the same thing, really.
It's the same thing, and look, I think the only way we'll get around that is actually talking to young people about sex.
Yeah.
Because, like, expecting them not to think about it till they're, 29, like, if the rest of society did that, we wouldn't have evolved. We'd all be dead, probably,
Yes.
So pretending that it doesn't happen doesn't make it not happen. So I think talking to people about it is the way forwards.
Yeah.
But what a lot of young men, like, so I would have young men coming into me saying that they have premature ejaculation or erectile dysfunction. And when you dig into it and get the details, they don't. What they have is unrealistic expectations.
Okay.
They expect sex to go on for hours and hours and hours.
Yeah.
And for it to be like perpetual and at the flick of a switch. And it's like, that's just not real.
Yeah.
Like, and so it's trying to explain to them. And it's not just young men that have those expectations, because there are young women are being exposed to more and more pornography as well and seeing it, and so they are having expectations of their partners in some settings and saying, well, it should go on for 60 years.
Goodness me, I know, and
which sounds exhausting.
Oh my goodness, the issues of that, and I was actually listening to a podcast there recently about an adult lady. I think she was around maybe a bit younger than me, but she learned about sex from porn too, and she said she was always performing, like a porn star, and that's how she learned. That's what she thought sex was. So these males that you're talking about are doing the same. It's just,
and it's so unhealthy for both partners in that situation, you know, and then the pressure builds, and then that often does lead to erectile dysfunction.
Yeah.
So erectile dysfunction is one of these unfortunate problems that the more you worry about it, the more likely it is to happen.
Yes.
So frequently, actually, I will prescribe medication like sildenafil or tadalafil on a short-term basis.
Okay.
So it can often give people, particularly if there is a significant psychological overlay to it. And while I would say that only 10% of erectile dysfunction is purely psychological, I would say there is a psychological component to all erectile dysfunction.
Okay.
Because if it's bothering you, you're thinking about it. And if you start worrying about it, it's going to become a worse problem. So sometimes having a short treatment with something to help you with your erections can take the pressure off for a while.
Yeah.
And it can give you your confidence back, and that can make a huge difference.
Okay. And can people get used to using sildenafil or tadalafil, as in they then can't get an erection without it?
I suppose with anything where there's a complex interplay between your physiology and your psychology, if you build a really strong ritualistic component into it, you could end up stuck with that. So like if you say, like, I have to take my tablet and then I have to go and have sex, you could end up not being able to perform unless you do take your tablet. But I think for the majority of people, I don't think that's a significant risk.
Okay.
I think there are some people who will need to use it permanently, but that's because of the underlying medical problems rather than an addiction to it per se.
Yeah, okay. And then in terms of the softer erection, like what you were saying as well, it's good to do the same thing like what you're saying.
So we can. A lot of the times the first thing I'll look at is, well, the first thing, just because I'm a GP, the first thing I'll try and look at is it my fault? What other medication am I prescribing for this person? Do you know, because there's a lot of medications that can cause erectile dysfunction.
Yes.
And so looking into that, are we causing your erectile dysfunction? Is
antidepressants
really
being one of them.
Antidepressants being one, some blood pressure medications being another, and then a lot of sort of more heavy duty mood stabilizers and stuff have a really significant impact on it. Then I'll often talk to people about their lifestyle, because so lack of sleep, things that are generally bad for your health are also not good for your erections, right?
Yes.
So having an incredibly sedentary lifestyle, eating a lot of unhealthy food, alcohol is the big one in Ireland.
Yeah.
You know? And people go like, well, my erections are fine when I'm masturbating on my own, but whenever I try to have sex, they're dreadful. And it's like, just tell me, like, what's the setting? And it's like, well, we'd always go out for like a couple of pints. And in Ireland, a couple of pints means any
6.
number except 2. It's definitely not 2. But it can be any other number.
You're so right.
So it's like, well, you know, let's try getting rid of that first, and seeing how it goes. So,
and it can have an effect the next day. The alcohol isn't just the day they take it. Sure, it's not that it's affecting the performance. Then it's actually can be the next day or follow through,
up to 72 hours later. So it has a big knock-on effect. Alcohol has a big knock-on effect on dopamine in your brain 72 hours later, and serotonin, and so those are really important hormones in your brain for your mood, but the nerves in your spine have to send a signal to your penis to get an erection, and it uses neurotransmitters. And if you are using something like alcohol, which has an impact on neurotransmitters, it's having an impact all through the body, you know? So it is something, if you are having difficulty with erections, give the booze a skip for a while. And one of the other ones that people don't like to talk about, because it's illegal and no one does it, is cannabis. And then the people who do like to talk about it won't hear a bad word said about it. Yeah. And I'm not here to finger wag and say
you shouldn't, or you should,
but it has a big impact on a part of your brain called your hypothalamus and your pituitary. And they are the parts of your brain that influence fertility and testosterone production and erections. So if you're using a lot of cannabis, that can have a big negative impact on erections as well.
Yeah. And then is there a difference between erectile dysfunction and low libido? You know, is there an interplay there? Because someone might they will really want to have sex. Yeah. They're feeling horny, but they can't get an erection. Yeah. So what is the interplay there? Because Viagra sildenafil, we're not mentioning brand names, it doesn't increase libido. It just gives an erection.
It just gives an erection. And the thing is, if you have absolutely no desire, the sildenafil may not work. Yeah. Because it is magnifying, or it's assisting the function that produces an erection.
Yes.
It's not causing it.
Yeah.
So some people will think that they have erectile dysfunction, but you're right. And sometimes it's the person's partner says they have erectile dysfunction.
Yeah.
And the problem is libido. They
Yes.
just don't want to have sex.
Yeah.
And if you have low libido and you're not getting erections and that doesn't bother you and you're happy out with your life, by all means continue doing that. That is your own business. And libido, like I get people coming and asking me what's a normal sex drive.
Yeah.
And it's like, yeah. Like, what do you mean? It's like, there's no such thing. It's, you know, it can be anything. It is what works for you in your life. Do you know? So if you are the type of person who is happy having sex once every 2 months and you have a partner that works with, happy days.
Yeah.
You're away, do you know? If you are the type of person who wants to have sex twice a day and your partner feels the same, that's also great. It's when you have a mismatch, it becomes a problem, where one partner has a significantly higher sex drive than the other. And what I would usually say if that comes out is I usually put my hands up and say, do you know what, I stick to simple things like medicine.
Yeah, I don't want to go down to psychology.
So you need to go and talk to a psychologist who deals with psychosexual counselling and stuff like that. And that can be really helpful. And I suppose at one extreme you have people who are completely asexual, who have no sex drive whatsoever. And then at the other extreme, you have people who have an out of control sex drive, and whether you call that sex addiction or hyper libido or whatever you want to call it.
Insatiable. Some woman described her husband as he's insatiable.
So, and again, if that doesn't cause you problems,
happy days.
Who am I to judge?
Yeah.
But if it's causing problems, you should probably look at doing something about it.
Yeah. No, agreed. You know? Yeah, 100%.
And talk about it. Like, talk about sex is the one thing that every person who's alive on the planet has in common in their history.
Yes.
So we should just talk about it.
I know.
Not all of the time. It's, you know, not as much as we
you might get in trouble if you're talking about it all the time.
You might do.
And it's interesting that you alluded to the whole school educational system. I know that they're trying to change it, but really we are at a disadvantage here in Ireland because there's, you know, it's still, I think, now I still all about reproduction, penis and vagina.
Yeah.
You know, there's nothing about pleasure. And I think that if schools and, you know, particularly secondary schools, but even from the start of primary school, I know that with my kids, I try and talk about, you know, it's about pleasure, it's about love. Yeah. And if we started that conversation, I think it would help people as well. But
it's funny, so I have young kids. I have an 8 and a 6-year-old, and myself and my wife were chatting about it, about, you know, what'll we, and we kind of said to each other, look, well, if they ask direct questions, we won't lie or avoid it. But we then got, we read to them, and someone gave them a book called Kay's Anatomy, written by a UK doctor called Adam Kay. And we read through it and they were fascinated by it. And it just went through the whole chapter on sex and sexual reproduction.
Yeah.
And reading it to an 8 and a 6-year-old when there's no overlay with it. They have no preconception about it. They don't care about it. It's the exact same tone as we were reading the chapter on the heart to them.
Yeah.
You know? And it's like, oh yeah, then they know that. And so then, hopefully, when they're 13 or 14 and someone says, do you know how people get pregnant? And it's like, yeah, I do. It's just, here it is. And then you can start talking about the relationship side of it and the pleasure side of it at a later date without the whole, oh, no, you can't talk about that because it's taboo. Do you know?
Yeah, no, agreed.
So I think introducing it in its most basic terminology at the start is the way to go. Although it's very funny, my older son went to creche one day, and when he came out, the teacher said, we had taught him the day before the proper words penis and vagina.
Oh, yes.
And that his daddy had a penis and his mummy had a vagina. And he had apparently gone into creche and told all the girls that they had vaginas.
Oh, lovely.
And they were very upset about this.
Oh, you see, and that's the thing, isn't it?
Like, he said, I have a vagina. So the creche just said, look, just if you're going to talk about stuff like that, just let us know.
Because your child's basically, he's doing God's work, educating creche.
It was just so funny because we hadn't thought about that, and I suppose that's something we probably
I know, I'm always a little bit worried because I'm very open with mine. I'm always going, God, I'm just expecting a phone call from one of the mothers one of the days, or, you know, a WhatsApp saying, what in the name of God are you telling your kids? Because like that, if they ask a question, I'll answer it, you know. Midlife crisis, in men.
Yeah.
You know, what is it? Can men go through several of them? I can think of a few men that I know that have had several midlife crises. You know, is it Is it, is it like the male menopause? Is it andropause? Is it to do with testosterone levels dipping? Men get, there is a term, it's a bit laughed at as well. And there's pejorative language around the male midlife crisis. Yeah.
You're just getting old. I suppose for me, when someone says midlife crisis, I'm thinking sports cars, dyeing your hair blonde and
running off with a younger
woman. I don't know how anyone affords any of those things, but it's an interesting concept. I think there's a couple of things in that. Andropause is an interesting thing. Male menopause is a really interesting thing, or age-related decline in androgen, as it's very catchily put in medical textbooks.
Yeah.
It's a weird thing, and it has almost it's had very little research done into it, because I guess it doesn't stop the male reproductive function doesn't really have an end point like it does in women. So there's not this really clear visible end point to it. Like if for women, they have periods and then they stop having periods, and it's a very clear, real thing. Whereas I think male versions of it have been sort of discussed, but not really acknowledged, I think, for a long time. It is an interesting question. And I suppose when I get people coming in with mood-related deterioration in their midlife, right, there's a couple of things that I always want to find out. Sometimes it's just a time, particularly around decade birthdays, that people take stock of what they've achieved and where they hoped they'd be. That can be, for some people, very upsetting. Or for other people, it can be very reassuring.
Yeah.
But I think for people who aren't used to definitely not talking about their feelings, but even acknowledging that they exist, that can lead to very negative, maladaptive coping strategies where they do just start lashing out at everyone because the world isn't what they wanted it to be or expected it to be. Now, I would always also look into the physiological side of things at that point. So I would send off a set of blood tests. So other things that can cause deterioration in mood and ambition and muscular strength and concentration. So thyroid function would be one of the most common ones. Iron levels, your vitamin B12 levels can have funny impacts on it as well. Your testosterone level, I would check. And so for anyone who's thinking about getting their testosterone level checked, what I will say to you is you need to get it checked early in the morning, because testosterone varies throughout the day. So an early morning fasting testosterone level is considered the gold standard for looking at it. So lowering of testosterone, your testosterone drops as we age, right? Your testosterone levels do go down. And so we get, this is one of the reasons why we get decreasing muscle mass and decreasing fitness levels. Now, how much of that is normal versus how much of it is pathological is really open to discussion. And I guess a lot like menopause, what I focus on is the symptoms that it's causing. Do you know?
Okay.
So if someone has symptoms that I think might be suggestive of a testosterone deficiency or andropause or male menopause, whatever you want to talk about it, I will get them to do, there's a 10-question questionnaire called the ADAM questionnaire, which is the age-related decline in androgen medicine, or I can't remember what the M stands for, but it's ADAM anyway is the name of the questionnaire. So people want to look that up and do their 10 questions themselves. It's a good screening tool for, does someone have symptoms of testosterone deficiency?
Okay.
The thing I would say, or I would caution people, is you may have a lot of the symptoms of testosterone deficiency and then you get your testosterone level checked and it's fine.
Yeah.
And that doesn't mean that medicine doesn't understand your testosterone. It probably means that there's another reason for these symptoms. So a lot of the symptoms of testosterone deficiency are very similar to the symptoms of depression.
Right.
And so we know that depression in men is very, very high in your late teens, early 20s, and in your 50s to 60s. So that's when rates of suicide actually spike in men.
Okay.
So mood-related stuff is very prevalent at those two age brackets. So I would always talk to men about their mood at that point as well.
And is the 50s to 60s, is that anything to do with they're getting older, they're seeing kind of the end of their life, it might be nigh, the best bit's gone.
The best bits are gone. And then often with retirement comes a loss of identity and a loss of self-esteem. And there is this whole concept of older men being made to feel non-important, useless.
Bit useless, yeah, because I've spoken to a few that, like post the baby making phase where the kids are small, or whether or not they've had children, but just that feeling of they're not as important as the mother figure, or they've had their career, the best of it's over.
Yeah.
I'm kind of put out to pasture almost.
And that's and like, and I'm sure I know for myself, it's talking to my own dad. My dad's great, but it's you're trying to strike that balance between not wanting to ask him to do stuff that you can do for yourself.
Yeah.
But also you want to let him know that he's still important and useful and a vast repository of information,
Do you know what? It's so interesting that you say that, because my little 11-year-old had a project to do on his grandparents, and he chose my dad. Now he wanted to do his other granddad and compare them, but the teacher wouldn't, because I said that would be really interesting just to compare their lives. Yeah. But anyway, he wasn't allowed to do that. He wasn't allowed to compare them. And maybe retrospectively that might be, and there might be a reason behind that. But anyway, he came away from a 45-minute chat with my dad, and he sees my dad really regularly, and he says, I didn't know Granda had such an interesting life, and he did this and he did that, and he used to eat slices of bread with sugar on top, and that was what he'd have for his dinner. And it's so funny, and I don't think I knew that about my dad either, because you don't ask them the questions, you're not going to get the answers out of them, because men by their very nature don't really talk very much. Whereas my mother, I would know a lot about her childhood, but I'd never, and I did remark to myself, I must talk to my dad more about his childhood. So it could be that, and it comes back to that whole thing where men don't talk. No,
and don't talk about, like they'll often talk about project or task-based stuff.
Yeah.
It's like, oh, well, here's what you do if you're putting up a shelf.
Yeah.
Do you know? But yeah, so but that was always the stereotypical role for men.
Yeah.
Like right up until just probably the 90s or early 2000s, it was like, no, you just, the strong silent type. Do you know?
I know.
No, he's out to work, never complains, never mentions anything.
Yeah.
And it's like, why is that something that we're striving towards?
Know.
Do you know?
Yeah.
Being silent and uninvolved. And the thing is, that all works okay while you're working 70 hours a week. Do you know? No one needs conversation out of you if you're not present for most of the time. But then all of a sudden your career ends and your kids move out, and what's left?
Yeah.
Do you know? And so I think chatting to people, and it's funny, like I would be the same. My kids get stories out of my dad and my mum that I wouldn't have known about their childhood.
Yeah.
Do you know? And just if you take a step back and just think about what your parents or older men and women have experienced in their life, like my parents would remember the first telephones being installed in the town that they grew up in.
Yeah.
And now we have all of human knowledge in your pocket.
Yeah.
It's crazy, do you know? And so actually just talking to them, making them part of life and not assuming that they can't make decisions and do things for themselves.
Yes,
I think is really important. But I do, sorry, we've kind of gone, I got sidetracked a bit, but it is that thing of there's a lot happens in that later life in 50 to 60 to 70, whereby there's an awful lot of moving parts. There is a lot of physiological stuff going on that should be looked at. And if you think that you do have testosterone deficiency problems, go and ask your GP to check it.
But it isn't like menopause, like what you said, where basically our ovaries shut down, we stop producing estrogen. No, so men do continue to produce testosterone, more than others.
Yeah. And so there's a couple of things that can impact negatively on your testosterone production. So men continue to produce testosterone till they die. Now your testosterone, most of it's produced in your testicles,
right?
At signals from the brain. So if you have problems that can have impact on your brain, so smoking, alcohol, head injuries, they can all have an impact on lowering your testosterone production. And then anything that's not good for your testicles. So the two sort of smoking and alcohol are the two biggest ones there again.
Yeah.
But eating very processed food, wearing very tight underwear, heated seats in cars, they're not good for testicles.
Long cycles either.
Long cycles. Yeah, sitting on your testicles for hours and hours at a time is not. Now, I'm being a bit facetious. You don't sit in your testicles.
Even I'm trying to figure out now how that can be done.
Very briefly and only once. But like sitting on. So you're sitting on your prostate more than your testicles.
Yes.
But so things that put a lot of pressure on down there can cause problems. And the other thing is carrying a lot of weight around your middle. So getting less physically active decreases your testosterone level.
Okay.
Because fat, particularly fat cells around your middle, they can convert testosterone to an estrogen type hormone. And so you may be producing plenty of testosterone, but you may be converting most of it to not testosterone.
Yeah.
And so getting more physically active, it's a funny sort of catch-22 situation with testosterone, that if your testosterone levels were higher, you might have more energy to be more active. And then if you were more active, you might have more testosterone. So sometimes it is, you can nearly force a change of lifestyle into it to try and treat that problem.
Okay.
And also that will have impacts on getting more active will improve your mood, it will improve your sleep quality, it'll improve your energy levels. So it's worth doing anyway.
And is midlife now 40s? Because you know the way we discuss midlife, like we are all living longer.
Yeah.
So is it around 40s that, you know?
Sounds very close to my age.
Well, it's my age. So I'm just, what is considered to be midlife?
I don't know. Like, I don't have a definition for it, I
Yeah.
guess. But like statistically, numbers wise, life expectancy in Ireland's about 80, 82 for men, 84 for women. So yeah, 41, 42 is midlife.
So I should be having my midlife crisis now soon.
So Maserati now next week.
That's it.
But it's one of these things. I think there is definitely, I think testosterone deficiency in men is something that needs to be looked at more. Mm-hmm. But I worry that sometimes people, because they hear people talking about it and talking about testosterone replacement therapy.
Well, Joe Rogan's a massive fan for the, even just the anti-aging effects of it and the more energy effects of it.
Yeah.
But does it shrink your testicles?
It would do, yeah. So if you give yourself what we would call exogenous testosterone, to testosterone coming in from outside your body, your testicles don't have to produce as much of it. Mm-hmm. And what happens then is your brain reduces the signaling to your testicles to make testosterone, so your testicles shrink. The other thing that people need to bear in mind is that if you are taking steroids, right, and I suppose we'll talk about anabolic steroids in a minute, but if you're taking testosterone supplementation, you will pretty quickly become infertile, right? Now, usually that reverses again when you stop the testosterone supplementation, but it can have a really big impact, particularly if you're taking higher doses of testosterone that put your testosterone levels above what would be in the normal range.
So is it something that you don't see a lot in GP practice, the testosterone replacement therapy? Is this things that people are getting on the they're getting on the internet and things like that?
I suspect they are.
Okay.
I suspect a lot of people who go for it are self-sourcing it, which is massively dangerous because A, you don't know what you're getting, and B, there's no one monitoring it, So it's one of those things that I really would encourage people not to do. The other thing is that if you start increasing your doses of testosterone, you may feel better, but there are a number of cancers that men get that are driven by testosterone. So prostate cancer and testicular cancer would be the big two. And then high levels of testosterone increase your cholesterol levels and they're bad for your heart. Mm-hmm. So if you're taking what we would call supraphysiological doses of testosterone, so higher levels of testosterone than your body should have, you're massively increasing your risk of testicular cancer, you're dramatically increasing your risk of prostate cancer, and you're increasing your risk of heart attacks and strokes.
Okay, so...
And that's if you're taking reputably sourced actual testosterone, does what it says on the tin.
Yeah.
If you're taking anabolic steroids, you're playing Russian roulette with your health, do you know?
So can we touch on that anabolic steroids? Because there's a lot of young men nowadays, they are taking those steroids to, I suppose, bulk up in the gym. Yeah. They're called juice heads, aren't they, or something like that?
Yeah.
And with social media and the way it's going, it's, men are under that pressure now, where I know they certainly weren't when I was a teen, but I'm seeing more and more teens coming in looking, buff.
They look like bodybuilders. Like they look, or anatomical models. Like
I know.
It's certainly not what most teenagers looked. Even muscular teenagers when I was a teenager didn't look that shape.
Yeah.
It's and I'm seeing a chunk of young men patients who are taking steroids and openly taking them, and will come and talk to me about it. And then the difficulty is, I suppose, anabolic steroids can cause liver failure, right? Yeah. They can damage your liver, and there are lots of things you can read saying, well, if you take X, Y, and Z, milk thistle and all of these things, and dance twice backwards under a full moon, it won't cause liver failure. But that is no guarantee, and I've seen 2 patients need liver transplants because of anabolic steroid use. So that's no joke.
And you can be guaranteed they're not getting these anabolic steroids from a doctor, from a pharmacy. They're getting them on the internet.
No quality assurance
No.
on them. Do you know? The second thing is, let's imagine somehow that you are getting them from a pristine source that is exactly what it says on the box. Do you know, it's whatever, nandrolone or something like that. It is exactly what it says. You are causing increased levels of testosterone. That's the point. That's the point of steroids, is to increase testosterone levels to give you more muscle bulking. You are, by definition, increasing your risk of heart attack, strokes, prostate cancer, and testicular cancer. And those risks, if you take it a lot in your teens, those risks stay elevated for your life. So your lifetime risk of testicular cancer, if you use bodybuilding supplements, your lifetime risk for testicular cancer usually goes up by about fivefold.
So it doesn't decrease once you stop.
No.
Okay.
No, because you're exposing your testicles to this massive dose of testosterone.
Okay.
And they don't deal well with it.
And do they atrophy as well then?
They can do.
Which means shrink.
Which means shrink. And so that can cause huge fertility problems further down the line. So like it is one of these things that, and what I would say to people out there who are considering it, if someone's telling you that they have a magic steroid that is not going to cause any of these risks, they're lying, because the only way it could cause none of these risks would be for it not to cause an increase in testosterone.
Yeah.
Which is kind
the opposite of what you want.
Purpose. Yeah.
Yeah. Okay. So you touched there on fertility, and how can men help with increase their sperm quality, sperm count, and then decrease the fragmentation, which is so, because there isn't more and more coming to the fore now, whereas women were always, I suppose, it was always seen as a women's problem. It was an issue with them, but now I think it's 1 in 6 couples can have trouble trying to conceive.
That's right. And one of the big things that I was taught in college, which surprised me as a medical student and is still the case today, is that so 40% of cases are purely male fertility problems, 40% of cases are purely female fertility problems, 10% of cases are shared, and 10% of cases are unexplained. Yeah. So it's equally, it's not a woman's problem.
No.
And I still get patients coming in saying, my partner, he says that I should get checked for my fertility because we're struggling to conceive. And it's like, grand, and who's doing his semen analysis?
Yes,
it's like, his what? And it's like, you're not doing this on your own. Sperm counts and fertility is an interesting topic in men, and actually it's going to become even more interesting and more topical, I think, because there are some medications. Male fertility pills are in late stage of trials at the moment, or male contraception is in late stage of trials at the moment. So it'll be interesting in this space in the next 5 or 10 years.
I don't think I'd ever trust a man who says, "Don't worry, I'm on the pill."
No, I don't think so either. But for men, I think there will be a group of younger men who don't want to just necessarily trust a woman who says she's on the pill.
Fair enough.
You know?
Yeah, absolutely. But there'll be a smaller
uptake. The responsibility of both, I think.
Yes.
But so male fertility, a lot of the things we talked about with testosterone are relevant here again. So physical activity, right? So being active increases your testosterone level, and it can increase your sperm count and your sperm quality. Okay? Up to a point. If you're training for ultra marathons or things like that, that can actually have a negative impact on your hormones. A lot of the time your body then thinks that you're in a starvation situation and that it's a bad time to father children, so your fertility will go down. But if you're not exercising very much and you want to improve your fertility, get out and start exercising, okay? Eating processed foods decreases sperm quality.
This advice is so boring, Phil. I thought you were going to come out with something racy, but it's like, sleep more, eat better, exercise,
Isn't it sexy?
Yeah. If we could come up with something different, we'd be millionaires.
I talk about drink, and it's not good either. And smoking's not great.
Yeah.
But no, so for sexy stuff, then turn off your car's heated seats.
Okay.
So heat... your testicles are outside your body, not because it's an easy target for when people want to kick you when you're in secondary school. They're there because they need to be at a lower than body temperature to produce sperm. So heat has as big an impact on sperm count as smoking.
Okay.
And something having the same impact as smoking is something that we almost never say in medicine.
Yes.
So it's really big.
Okay.
Doesn't have the same impact on sperm quality, so fragmentation and motility and things like that.
Yeah.
But for absolute count, it is as important. So loose fitting underpants, turn off the heated seats in your car. Don't sit in the bath for 6 hours. Do you know?
Yeah.
Leave off the hot tub, leave off the sauna. If you're trying to have kids, don't do those things.
Okay.
And the big thing is that so for female fertility, it's a month-to-month thing, right? The egg is released and that's the egg there for this cycle. Male fertility is kind of like a conveyor belt. So any changes you make can impact for the next 3 months, because it takes 3 months from the start of the production of a sperm to it being ready and mature is a 3-month cycle. So there is kind of a 3-monthly conveyor belt going on in the testicle producing sperm. So you need to make these changes and you need to sustain them for 3 months.
Okay.
But heat is the big one that people look at me like I'm talking.
Yeah, people don't actually realise that at all. Sure they don't.
No.
And then getting on to the opposite question is vasectomies. So people are, I'd be all for vasectomies, particularly if someone's finished their family and the female wants to go off hormones or whatever she's been on for the past 20 odd years. They're, safe and simple. But is there a downside to vasectomies? What is the statistics on that? How do you perform them yourself?
I don't at the moment. I've always said that I would like to get into doing them. So if we can find 2 more GPs to hire in our practice, I might well start looking into training up to do them if I had the time.
Yeah.
Because I agree with you. I think they're a fantastic procedure. I think they're a great option for people who are finished their family, and to take all of the responsibility off one partner. And like you were saying, so women have been manipulating their hormones for 20 years. It's about time someone else took responsibility for it. For the vast majority of men, there's no negative side effects, right? You get a very minimally invasive procedure done. Usually they're done without cutting now, so it's a non-scalpel procedure. It's done with a needle. It's a very straightforward, quick procedure. I have friends who are GPs who have had it done and gone back to work the rest of the day. Mm-hmm. I don't recommend that, but
those high achievers.
Yeah.
I know a man who got it done and cycled home from it. Now that is not recommended. He had bruised testicles, so definitely follow the instructions from your doctor. The doctor definitely told him not to cycle home, but he jumped on the bike and did it anyway. So I know. Can you imagine?
I'd rather not.
No,
but I suppose the big risk there's 2 big risks with vasectomy. The first, and the one that you'll always hear being told about if you go for a vasectomy is that it doesn't work, right? Is that you can still conceive kids after you have your vasectomy. And in most cases, that's because people didn't listen to the next part of the talk about their vasectomy. So you need to have 2 clear semen samples after your vasectomy. Mm-hmm. Oh, and that's one thing actually that people always bring up to me. A lot of men worry that if they have a vasectomy that they won't ejaculate. Yes, that's a question that is often spun around, but it isn't the case. No, so sperm, which is made in the testicles, comes up through these tubes called your vas deferens. That makes up about 1% of the volume of ejaculate. So 99% of what comes out is not sperm. And it was the vas deferens of the tube that comes up, and that's where the vas in vasectomy comes from. That's what's cut. So your sperm volume might go down by a maximum of 1%, which no one will notice. No. So it's not going to make any difference to the quantity or quality of the semen that comes out. But you need to have 2 consecutive negative samples, because there can be sperm in the part of the tube above the testicle. Mm-hmm. So you make a cut in the middle of the tube, there can still be sperm in the upper part of the
little lurkers.
Yeah, and they can come out and cause havoc. Hanging around.
I'm gonna really screw this fella's head.
They have a plan. They've taken on debt. Let's give them another child. And so that can cause problems. So just bear that in mind, and it can be up to 6 months to clear out any remaining any remnants. Yeah. Or
I think 18 ejaculations or something like that. That's so if you're willing to get a diary and count.
One, as a teenager, you could probably do that in a week. But
so true.
It might take longer. So it's about looking into that. The most serious risk, I would say to people, is pain, right? So for the vast majority of people, it is a sore procedure on the day and for maybe a couple of days later, and then the pain goes away. Some people will have persistent pain. So persistent pain is up to 6 weeks. And then about 1 to 5% of people can have chronic pain or permanent pain. Okay? Okay. Now that's not something anyone wants. No. All right?
And that's all the time, not just when they're having sex?
No, that is continuous testicular pain. Okay. And sometimes you can go and fix that. Sometimes you can do a surgical intervention to fix that, or a pain relief intervention to fix it permanently. there is a very small number of people who will be left with permanent pain. And there's no real way around that, but it is very, very small numbers. Now, what I always say to patients when I'm talking about statistics is, if I tell you that it's 1 in 1,000, it's not going to be much comfort to you that 999 other people don't have this problem. Do you know?
Yeah.
So you do need to bear that in mind. Having said that, I still recommend it to people. I will get it done when we are definitely finished our family.
Yeah.
And I think it is the way to go. The other thing I will say to people, because I sometimes see, particularly in the States at the moment, because there's so much talk about the repeal of Roe v. Wade, and there's so much talk about reproductive responsibility. And there's a lot of people saying we should make all young teenage men get vasectomies because it's reversible.
Oh my goodness, Jesus Christ, no way.
And so it's not reversible,
No.
right? In some studies, 50% of vasectomies are mechanically reversible, right? Which means that the tubes can be reconnected. There is very little data on how successful they are at people conceiving after that point.
Yeah.
So I always say to patients, if you're getting a vasectomy, look, if you change your mind 20 years from now, there is a small chance that we can probably do something so that you could father a child at that stage. But you should assume that this is permanent.
Yes. You don't do it with a view to,
You don't do it, we can reverse it in 10 years. No,
Yeah.
you should make your mind up that you're doing it,
Okay.
is what I would say.
Okay. Men and incontinence and wetting the bed when alcohol on board, but then also the urgency, when just normal urgency, if they need to go to the bathroom really quickly or they have leaking. What would you suggest for that? There's a few questions there, so feel free to answer them all separately.
Go and talk to your doctor, first of all.
Yeah.
And don't be embarrassed about it. It happens, do you know? And what I would say is, if it happens to you once, don't freak out about it either, okay? Like, we all make mistakes.
Yes.
If you have continuous, I suppose, I'm going to break that into 3 questions. Let's go with the wetting the bed side of things first. If that suddenly happens and it's not related to alcohol, you need to go and get that checked out, okay? Because that means that you have a change in the sensation coming from your bladder and in your control of it, and that shouldn't really happen in your later years.
Okay.
So go and talk to your doctor. You need an investigation, okay?
Yes.
If you're drinking heavily and you wet the bed when you're drinking, drink less heavily.
Okay.
Do you know?
Fair enough.
Or set an alarm to get you out of bed to go for a pee after about an hour.
They're just sleeping through their need to go to the toilet,
the toilet, yeah. And so
I know of some men that get up, think they're going to the toilet and they pee in the wardrobe and things like that. You know, there's is that just to do with having a willy? Because I haven't heard of women doing that. Like, is that just to do with the fact that you can actually take your penis out and pee anywhere you want, really? Whereas we can't really.
It's frowned upon.
Yeah.
Well, we don't go looking for somewhere to sit, I guess, is the big thing. Do you know?
Well, that's the thing. So in your drunken state or your drunken / sleepy state, you're like, oh, this looks okay. Whereas we would always we need to put our pants down and actually sit on something. Yeah.
But and that's it. Like, so you could, I guess, I don't know. Did you ever sleepwalk, or do you ever remember sleepwalking?
No, I didn't.
I remember
I think I did once, but.
And the only reason I knew it was sleepwalking is I could remember what I had thought was happening, and then someone told me that I came out of the room and did X, Y, and Z, and it's like, but I can see that I was in a different room.
Okay.
You know? So I guess they could get up, walk. Their brain is telling them that they are standing in front of the toilet.
Yeah.
And then they pee.
Okay.
So there's no tactile feedback that I'm not sitting on a loo.
Oh, yes.
So what I would say is, if you do have these issues, just sit down when you're peeing at night. But it is one of those things. And so, like sleepwalking, it tends to run in families. There is a genetic predisposition to being someone who gets up and walks around when you're asleep.
Okay.
And so that could happen as well with, and alcohol and stress make it worse. So that could happen more likely in people who have been drinking.
Okay.
The big thing is, when your bladder fills, it wakes you, do you know? And so if you are unconscious because of alcohol, it's not going to wake you. And the other thing is, it's going to fill quicker because you'll have taken more fluid on board. So you're going to be needing to pee. You're more likely to need to pee in the middle of the night if you've been drinking than if you weren't. And then if you're too unconscious to wake up to pee, you're just going to wet the bed. If you are outside of alcohol, if you're waking up very frequently at night to pee, I would be concerned, and I would definitely want you to go and have a chat to your doctor about your prostate. And so this would bring into this would bring us to talking about urgency as well. So the symptoms of prostate enlargement or prostate problems would be frequency, so you need to go to the toilet a lot. Urgency, so when you need to go right now. Difficulty starting or difficulty stopping. and then a feeling that you're not emptying your bladder fully, right? And one of the big signs can be poor stream. And that's one that men often ignore. So they go like, oh, I'm peeing. But it's like, is it still hitting the back of the bowl with as much force as it used to? Do you know?
The things you have to think about.
There you go. It's complicated, man. I used to work with or when I was a student, I remember a urologist who was saying, could you still pee over a 6-bar gate? And now I think that's a pretty extreme standard to set.
That's impressive.
People.
That is impressive.
It is. And look, I don't hold my patients to that standard. I think that's a bit much, but you should still have a good flow.
I might take the lads out and see if they can do that.
Yeah.
It's a good pitch them against each other.
I guarantee that is something that has happened at some stage.
I can imagine.
Like, definitely in urinals in school, it was a known competition. But it's like there should still be a good flow. And a lot of men then bury their heads in the sand if they have these problems, because they go, well, if I have prostate cancer, I don't want to know about it.
But it generally isn't prostate cancer. And I think people need to understand that.
Cancer.
Because men, like you say, they tend to bury their heads in the sand. They don't want to go. They don't want to told the negative news. But in actual fact, it's very easily fixed.
They also probably just don't want the examination of the prostate done, which is understandable. Yeah. But look, I remember turning around to someone on a Thursday. It was Thursday morning, and I had just examined his prostate. And he goes, "Oh, this is probably the last thing you want on a Thursday morning." And I said, "I don't know how many of these I've done." And he said, "This year," and it was this week.
Yeah, they don't realise that. Like,
it might be 10, but it might be 12. I don't know. It's so run of the mill. You know? Most of the time it's prostate enlargement. It's what's called benign prostatic hypertrophy. And the best word in that is benign. Mm-hmm. And so it's where there are 3 things that continue to grow throughout our life: our ears, our nose, and then if you're a man, your prostate. And they never stop growing. And so prostatic enlargement is something that happens to a lot of people. And most of the time you can manage it either with lifestyle changes. So you reduce things that irritate your bladder. So spicy food and caffeine would be the big 2.
Okay.
Unless you smoke, in which case I tell people not to smoke, but there's no interest in telling people that anymore. Everyone knows that. But spicy food and caffeine are the 2 big ones.
Okay.
And for some people, you do that and you tell them, look, stop drinking water after 6 o'clock in the evening, and that fixes the problem.
Okay.
For other people, there are medications we can put them on, which reduce the size of their prostate, and it can fix the problem entirely. And then for other people, there is surgery, which is usually really well tolerated, which can remove part of the prostate and fixes the problems as well.
Now, those surgeries and medications, can they have an effect on erectile dysfunction?
Absolutely they can. The surgery tends not to. So the surgery tends to be a pretty safe one where they go in through the penis and they remove part of the prostate from the inside. So that tends to be keeping well away from the nerves involved, although complications can happen. And there is actually a new type of procedure, which is called a Urolift procedure, where they go in and they actually they pin the prostate away from the tube.
Okay.
So they're not even removing any of it. They're just pinning it up off the urethra.
Like a hoisting.
It's for all the world, it looks like, do you know those little document ties that have a metal thing that you line up and you push through and then you flip 90 degrees.
Oh, yeah. Okay.
So it's like that.
Right.
And they shoot it through and it just pulls. I think it's fascinating. Sorry.
It's amazing, isn't it, what they're doing nowadays? I'm always fascinated with all these new techniques and everything.
I think medicine's cool.
Yeah, no, it is.
Stuff in it.
It really is, isn't it?
But so there's lots of options with it. Involving surgery or not, and they can be really effective. The medications can cause infertility or can cause erectile dysfunction because they inhibit testosterone a lot of the time. And so there's one of them particularly which we also sometimes use for hair loss and baldness, and it can cause problems with erectile dysfunction. Now it doesn't usually, but it can.
Well, interestingly enough, Phil, this brings us on swiftly to my next topic, which is hair loss.
There is one last thing I want to say about the prostate, though.
Go on.
If you suffer from constipation, it's going to make your prostate symptoms worse.
Okay.
Because if your rectum is full of poo, it's pressing forwards on the prostate.
Okay.
So if you don't eat any fibre and you're having prostate symptoms, you don't really want to go and talk to anyone and get it examined, just start eating more fibre and drinking more water and get the bowels going. Okay.
Good advice. And you know, fibre is fruit. There's fibre in fruit, and some people don't realise that. Even if you just increase your fruit intake, your vegetable intake, you don't need to be eating bran flakes and all bran and all these, and you don't need to be buying fibre gel from the pharmacy. It's literally just increasing your roughage.
Increase your roughage. Increase it. Berries are actually really good because they have so much skin relative to the fruit size.
Yeah,
and they're great for fibre. Bananas are not good for fibre.
No, they're not.
So,
if anything,
just be
bananas
aware.
will actually
They'll
constipate
bind
you.
you up.
Yeah, absolutely.
Just be careful of that.
I was always giving that to my kids and they had a little bit of diarrhea. So anyway, the hair loss issue is huge actually. And it can really negatively impact on a man's self-esteem, particularly if they're younger men, like late teens, and they start to lose their hair. There's a whole industry now around hair growth.
Yeah.
There's lots of promises around things that people can take both orally, slap on their head, and then there's clinics that offer support too. So can we maybe delve into that and what you see in GP yourself, and then what advice you would give to young people and older people too? You have a fine head of hair yourself, I must say.
Hairdressers, everyone in my family, when we go to hairdressers, they swear because of the density of our hair. My sisters genuinely get given out to whenever they go to the hairdressers. Baldness does not run in my family, which is funny because it means that I kind of didn't put any research into this till I was actually asked to write a newspaper article on it, and then the more I researched it, the more interesting it becomes. So hair loss, early male pattern baldness or androgenic hair loss, early, which is defined as in your teens or 20s, happens to 25% of men, 1 in 4. So like certainly there was a handful in my year in secondary school who were going bald before the end of secondary school.
That's tough going.
And it is rough. And I think for people like myself who don't have any issues with thinning hair, although if I live long enough, my hair will thin. It happens to everyone. I think it's very easy for us to denigrate it, to say like, it's just your hair. Are you that vain?
Oh, and isn't that, it's a real bugbear of mine, accusing a man of being vain because he's upset about his hair falling out. Like, I mean... But
even if he is interested in his image, why is that a bad thing?
I know. You're right. You're so right.
But it's not vanity. It is a big thing. And I think for people who don't suffer from hair loss, it's very hard to fully understand how noticeable it is to the person whose hair is thinning. They see it. They see it all of the time. When they look in the mirror, it's what they see. In photographs, it's what they see. You may not even know that person has thinning hair, but they will know that they have thinning hair and they will see it all of the time. And it can really get inside your head and cause, it's a significant risk for increased depression, for dissatisfaction in relationships, for job problems, because people just get really upset about it. And so baldness, if it does bother you, if it doesn't bother you, great, because it's not medically dangerous.
No.
So if it doesn't bother you and you're happy enough, and I don't know, maybe you just shave your head and you just go on living with it, great, good for you.
Is it a sign of having higher testosterone levels than the next man, or not?
No. It's It's one of these things.
Are you just saying that because you have a massive set head of hair?
Pass. It's I've never been accused of that. It is one of these things. So there's a couple of myths with hair loss, that it's a sign of high fertility, low fertility, high testosterone, high virility. There's a huge genetic component to it. So these rumors start, or these myths start, because there is a link to testosterone, right? So what causes male pattern baldness, or what causes the hair follicles on your scalp particularly to die, is a thing called dihydrotestosterone. DHT, because I don't want to say that word again.
I can draw the organic chemical of that.
Well, you could draw it and I could walk past it, so that's fine. And it is a product that your body converts testosterone to, and some hair follicles are more sensitive to it and convert it at a higher rate than others. And so you can have high testosterone levels and your hair follicles be very bad at converting to DHT and you won't have baldness. Or you can have normal testosterone levels and just very sensitive hair follicles and you will have baldness. So it doesn't really reflect what's going on hormonally, other than you have testosterone.
Okay.
Do you know?
Yeah. And I think it's important what you said there as well. The hair follicles die and you can't bring them back to life.
No.
So no matter what, once the hair has fallen out and the follicle is dead, you can thicken the hair and you can cause the hair to grow if the follicle is still alive. But what happens is that when it dies, it's dead.
Yeah. And what a lot of the products that are available, and like some of them work really well, minoxidil, which is the most commonly used topical product that works. I'm sure there's other common ones like, I don't know, caffeine and guano or something.
Yeah.
But what it does is it increases the blood flow through the scalp, and the idea is that it washes out this DHT faster, and so you will get some of the hair follicles that are gone to sleep but aren't dead yet, so gone quiescent, will start producing hair again, and it can work really well for some people.
Yes, but it needs to be on it all the time, though. You can't just go on it, see the hair growth, and then go back off it. It needs to be, it's permanent, and it's expensive. And I usually draw a little graph for people, and I say, look, it may level your hair loss, your hair quantity here, but when you stop, your hair is not really going to go back to where you started at. It's going to go to where it would have been had you not treated it a lot of the time. So it doesn't prevent it. Then there's medications like one of the ones we use for prostate enlargement, one called finasteride, which we can use for people with hair thinning. And it's funny, so before I did any research into hair loss, I would have absolutely refused to prescribe finasteride for hair loss. That's so interesting. I remember seeing
an issue that
I know, but I remember seeing the prescriptions coming in, and I'd be thinking, why is this fellow? Why would he be taking drugs for this? And it's our own. Why is he
on a quarter dose?
It's our own prejudices, though, isn't it, that come through?
But I would have said, well, no, I've read the downsides to it, and really for something that's purely cosmetic.
Yeah.
And then I read about it, and I talked to some people with it, and it's not purely cosmetic. It's a genuine issue. Finasteride can work really well while you're taking it. And so what it's doing is it's blocking the conversion from testosterone to DHT, and it can help with the hair follicles that are there. The downsides to it is for some people, for about 10% of people, they can have andropausal symptoms. So they can get flushing, they can get sweating, they can get muscle aches and pains, they can get cognitive dysfunction, they can get decreased libido. Now, for the vast majority of people, that goes away within 3 to 6 months of stopping it.
Okay. But it continues for the time that they're on it.
Yeah. And so there is a recognized entity called post-finasteride syndrome, which affects about 1% of people who go on finasteride, and it can be permanent symptoms. So you can have decreased libido, erectile dysfunction, brain fog for forever, even when you stop it. So that's less than 1%, right? So 99% of people who go on it for hair maintenance don't get those symptoms.
Okay.
So it's something now that I will have a big long chat with my patients about, and if they want to go on it, I'll prescribe it for them.
And is it something, so once you present them with those statistics, because it's almost similar to the vasectomy and chronic pain statistic, so it's interesting because I'd almost say, vasectomy, great, go for it. But like when you're presenting me with that and you're saying, 1% possibility of brain fog, and I'll be like, oh God, I'd be hesitant to it. Where's that? So, what do people tend to go for it then when you say that to them? Or
people who have already done a lot of research into finasteride tend to go with it because they know this, right?
Yeah.
People who have come into me saying, I'm going bald and what can I do about it? And I present them with it, they don't tend to go on it, right?
Okay.
But what happens quite frequently is maybe 6 months, maybe a year down the line, they'll have tried minoxidil, they'll be sick to the back teeth of it. They'll come back in and they'll say, do you know what, I do want to try it.
Okay.
And then there are more aggressive treatments for it. So hair transplantation can be definitive, do you know? So what they do with hair transplantation is they take, so you'll often notice the people who have male pattern baldness, they'll lose all the hair on the top of their head. But let's say on the back of the nape of their neck, they'll have plenty of hair, or elsewhere on the head, or elsewhere on the body. And that's because different hair follicles, different geographical hair follicles, have different sensitivity to DHT. So if you take them from an area that androgen doesn't affect and transplant them up to the top of the scalp, you can often have very, very successful results.
So they're taking hair from the man's body and they're putting it, so it's not taking hair from another person's body, it's always the male's body. Always, even if they're not a very hairy man, it can be done?
I don't know. I don't do them. But so
I'm just thinking, there's hairy chested men and then there's men that have nothing on their chest.
But I suppose what a lot of the times what they do is they actually try and take it from the nape of the neck.
Okay.
So it's because a lot of the times, particularly with male pattern baldness, androgen based baldness, it's the top of the head gets thin and goes bald. So if you can take hair follicles from the back of the scalp
Yes.
and transplant them up, it's the same quality of hair as well.
Yes, where it might be very different in different parts of the body. I understand
You
that
don't
now.
necessarily want a head full of pubes.
No,
Um,
no, you
possibly.
don't. Unless you're going for the curly duck.
unless,
you know?
well, look, and who am I to judge again if that's what you
Exactly.
do want to do?
What's the maintenance like when someone gets that done? You know, what is the downside to it? It's expensive, I know,
It's
certainly if you
expensive.
get it
It's
done in
very
Ireland.
expensive. Yeah.
I know a lot of people go to Turkey to get it done, or,
Yeah.
you know, other countries.
And look, traveling to get surgical procedures done has its own risk, and that's another hour-long discussion in and of itself. Which, other than to say, if you don't have to go abroad to get it done, maybe don't go abroad to get it done.
Yeah.
And that's not because Irish doctors are better at doing it. It's just that they're here for follow-up if there's issues. I think that the follow-up, it's quite painful initially, and I think that you do need to be very careful in the early stages of it. But then I think the follow-up is not particularly intensive.
Okay, so they
Afterwards.
can wash their hair as
Yeah.
normal, and is it permanent?
Yeah. Ideally, it should
Okay.
be, because it's hair. They're taking follicles from areas of the scalp that are not prone to male pattern baldness.
And it just keeps growing, isn't it amazing?
Should do, yeah. Now, the thing I find amazing is that there's someone involved in that process who sits under a microscope and separates out each individual hair follicle on a piece of skin.
I would have not
Nope.
the
No,
patience.
I'd kill someone.
Oh, I just wouldn't be able for that either. No way. We touched on it a little bit earlier, and I'd like to kind of get back to it as well. We touched on it when we were talking about the male menopause, and then on the hair loss as well, affecting males' mental health. And it's probably a topic that has been done to death, but then hasn't at the same time. And just the whole thing about men and the fact that they're less inclined to talk to people about their feelings, you know, God forbid. But the effect that can have on them, their overall health. You know, I learned very recently that someone that I knew, that I thought I knew well, that I'd been going in and out off to the shops for years and years, but hadn't seen in about 2 to 3 because of COVID. I'd stopped going to that shop. Died by suicide 2 years ago. I was absolutely shocked. I only found this out recently. A young man in his 30s, beautiful young man, everything going for him. And that happens way too often in this country. And, you know, depression in males and the fact that males aren't as inclined to go and get help as soon as females. What can we do to A, raise awareness, B, you know, what do you see in GP?
Like suicide in men is awful, and like we're encouraging men to talk about it more. The numbers are still going up. Do you know, like the last stats I got were 2019, so there was 524 deaths by suicide in 2019 compared to 140 road traffic accidents. So you are 5 times more likely to die by suicide than in a car crash.
And there's much more awareness of car crashes.
Yeah. And so 80% of them are men. For men aged 15 to 25, it is the biggest cause of death, which is just awful.
Yeah.
And like I've had 2 colleagues kill themselves, and I can vividly remember hearing about it. You know, when it just happens, and you never forget about it. If I had an easy answer to how we can stop men killing themselves, I'd probably get a Nobel Prize for it.
Yeah.
We need to encourage men not to see depression. Well, we're working on reducing stigma for mental health, right?
Yes.
So depression is now something that you're allowed to have, which is great.
Yeah.
You know, and you're allowed to get treatment for it, and
you're not crazy.
You're not crazy, and you're not weak.
Yeah.
You know,
it's the weakness thing, isn't it?
If I would say 20, 30 times a week at work, I'm talking to people who are going, this isn't weakness. No more so than someone who needs to go on blood pressure medication is weak because they can't keep their blood pressure down. Do you know? That's not what it is. Do you know? And we know that there's a huge genetic component to depression, and that there is lifestyle stuff to it. And for people who the medication works for, it works really well. And one of the big, and it's slightly off topic, but I'd really love to get this out there. Like, so modern antidepressants are not addictive. They do not sedate you. They are not permanent for most people. They're not something you take on one day and not the next. You do take them consistently, but generally speaking, 6 to 12 months. And then most people come off them.
Yes. And come off slowly with your doctor's advice, guys, always, because it's so important to not just hop off them. Like, it's good, you need to reduce down, certainly off certain ones that you need to reduce, titrate down off them.
because it can be super unpleasant if you don't, but they're not, they're not. And people turn around and they go like, oh, well, I know someone who's on antidepressants and they're in an awful state. And it's like, well, firstly, you probably know 10 people on antidepressants.
Yes.
You just only know about one person. And the only person you know about is the person who they're not particularly working well for.
Exactly.
So don't be afraid of talking to your doctor. I'm not pushing medication. I almost never prescribe it on the first visit with a patient because there are lots of other things to it, but we need to get over the stigma of it, okay?
Yeah.
Because it does reduce rates of suicide. And men are killing themselves in a horribly high number.
Yeah.
It's frightening. And one of the big statistics that is not often talked about is that one of the reasons that male suicides are so much higher is that men tend to be more violent about it.
And more impulsive. It's more like a decision they just decide.
So
almost.
they just, exactly. A lot of the times they've been thinking about it for months or years, but the decision to do it is an impulse. Mm-hmm. You know, it's almost like I finally built up the courage to do this and I'm done. That's it. I can't do it anymore and I'm gone. And they tend to choose methods that have much higher, it's a horrible phrase, but much higher success rates for suicide. There are much lower suicide attempt rates in men, because most of them kill themselves.
Most of them are actually successful.
Yeah.
Is it true that when they take people who have attempted suicide and then weren't successful, that they're happy that it wasn't successful?
From what I've seen, about 50 to 60% of people who have tried a suicide attempt that they really thought was going to work are pretty happy when it doesn't.
Yeah. Which is... Which
sad. Is sad as well. There's an interesting study with survivors who jumped off the Golden Gate Bridge to try and kill themselves. And all of them went on to live long lives afterwards. And it was an instant of perspective. But what's horrendous is they all said that when they jumped off the bridge, they realised that all of the problems in their life could probably be solved except for one, which was that they were falling from the Golden Gate Bridge. And it is that suicide is a permanent thing. And the way you feel, it doesn't have to be, you know. And the problem with depression is what it does to your thought process. So depression makes you feel that it's your fault, that you're beating yourself up continuously, that you don't deserve help, or that no one else will be able to help you anyway because they don't understand what's going on with your life, or these are just concrete things that are happening that no one can fix, you know. So it's that... You bought a house at the wrong time and you're negative equity and it has pyrite or mica and nothing's ever going to be okay. Do you know?
Yeah.
Or
that financial thing is important actually.
It's huge.
Yeah, because I think that, you know, we just consider it to be, they're depressed.
Yeah.
But actually a lot of the time there is a reason why they are, and financial instability and worry is awful.
And one of the big things with depression, so people think of depression as, you're sad. It's like, no, I'm not sad. That's not what it is.
Yeah.
I am dejected and hopeless and angry and tired. You know, and tiredness is one of the big things with it.
Yeah.
And a lot of the time suicide comes out of not from anger or from the world will be a better place if I'm gone. It's that I can't do this anymore.
It's like the black dog chasing you, isn't that the way someone...
And I can't run anymore. And if I have to put 100% of my mental energy into being okay, I don't want to do it anymore.
Yeah.
And so that often is a symptom of low serotonin levels, right? And so this is one of the things that I talk to patients about when they come into me. It's like that there are a number of depressive symptoms that make it more likely that you will actually respond to medication. So if you're getting constant rumination, which is where your thoughts chase each other continuously, this is the one where you're lying in bed at night and you go, and then they said this and I would have said that and they would have said this and I would have said that. And all of a sudden you're having a full-blown argument in your head. Okay. Both sides of it. And you go like, or what happens if I, from my own job, like what if I got that diagnosis wrong and they'd make a complaint and the complaint would be upheld and I'd lose my job and all of a sudden I'm homeless and my kids are homeless. Do you know? And so it's that continuous racing and cycling. And then sort of things like early morning awakening. So waking up in the middle of the night and not being able to get back to sleep and not having the motivation to get out of bed. Yeah. A lot of the times people see, well, I only feel this way. And that's a phrase I hear a lot. I only feel this way. Doctor, I only feel this way because. because of my relationship, because of my parents, because of my leaving cert coming up on me, because of my school friends, because of my job. And a lot of the times when you go through this, and if you put people on medication that suits them, that helps. And if it is the right thing for them, it can help them get to a place whereby none of these things have changed, but their ability to cope with them and deal with them is much higher. Because one of the things that you're removing is you're often quietening down that continuous racing inner monologue. And that gives you some mental energy and mental fortitude to go and actually make decisions about other stuff.
And I think it's important there that you said it's the coping mechanism. And it's not that people can't cope because they're weak or not strong or not as strong. And you can have two children that are raised in the same family that have had the completely same upbringing, and one may have depression and one may not. Yeah. And it's not a sign that one is weaker than the other. No. It's just the way they are made. It's their chemical makeup as well. But I think it's important to realise too, and I think that, sometimes antidepressants don't work for people. No. The first go, the second go, they might need to chop and change.
And a lot of times patients will come, "Oh, doctor, you don't know what you're doing. You're just trying anything." And it's like, well, we don't fully understand how they work, to be honest. We know what they do, but we don't fully understand how they work. And so therefore we can make a really good educated guess at which particular antidepressant might be the best for the individual case. But sometimes you don't know till you try it. And then if that doesn't work, or if it causes side effects, you put them on a different something.
Yeah.
What I will say is as well, antidepressants on their own are almost never the solution. No. But sometimes you need to think of them first, because you don't have the mental reserve to make the changes that will make the problem go away forever.
Yeah.
And the best description I heard of them was from a psychologist who said it's like putting scaffolding up to fix a house. The scaffolding doesn't fix the house, but it lets you get up there to do it.
Yes,
and then when the house is fixed, you get rid of the scaffolding.
That is a good analogy.
Slowly and safely.
That is a good analogy. And then that brings you into the whole thing about anxiousness, and then, all that mental health issue, it falls under the one umbrella. But I know that we often hear the word anxious or I'm anxious bandied around nowadays. And it's particularly referred to with females. Yeah. But it is something that males can suffer from and have. And it's quite normal, or, it's quite... I'm trying to look for the word. It's not that it's abnormal that a male would have suffered from anxiety, that kind of way. And depression and anxiety sometimes go hand in hand, and sometimes one precedes the other. Yeah. And they're often,
Well, I usually say to people that depression, anxiety and stress are three sides of the one coin.
Yes.
They are just down to how it's expressed or how it's experienced rather than what's actually going on inside. Yeah. Because the focusing on serotonin-based systems helps with both of them. And if you are depressed, you probably have some anxiety. And if you're anxious enough, you will get depression. So they do go hand in hand with each other.
Yes.
And so sometimes I'll have people coming in with anxiety, and I start talking to them about antidepressants, and they go like, "But no, I'm not." And it's like, you're right. And then then that's a good message to me to step back and actually explain myself better.
Yeah.
But they are linked conditions, and a lot of the same treatments, particularly the non-pharmacological sides of treatments, can be the same for both. So improving all of the non-sexy things that we talked about, improving your exercise, improving your diet, decreasing alcohol, decreasing other substance abuse.
But often if someone is suffering, does have depression or anxiety, sometimes they're self-medicating with alcohol and cannabis, like we discussed. Yeah. They can't sleep. They don't have the energy to exercise. So as you said, the medication, and by no means, I know as a doctor and a pharmacist speaking here, but we're not trying to push meds. No. But sometimes that can be just that lift to get you out of that rut.
Just to get you out of that rut. It can be the starting point, and then you do the work to make it better long term.
Yeah, and there's cognitive behavioural therapy and counselling and all of that good stuff too.
And that's probably the more important side of it.
Yes.
To be honest, I think the medication is necessary sometimes. And the other thing is that a lot of people want relaxers.
Like diazepam, etc. Yeah.
And the thing is, they take them and they get an immediate response.
Yeah.
And it's like, but I took that, I felt anxious, I took that and I didn't feel anxious anymore. And you need to explain to people that that is not helping. It acts on the similar part of the brain to alcohol. It is like having a couple of pints.
Yeah.
Which is not a solution to many problems.
It's numbing the pain rather than actually allowing you to feel it and trying to manage it as well. I think that's important.
And it's addictive. Increases your risk of crashes and being knocked down by a car by about 10-fold, and then doubles your risk of dementia. So,
well, if that wasn't enough to put anyone off, I know, but it's interesting because we test for alcohol, but we don't test for benzodiazepines. And, although prescribing of them has got much less in recent years, there's still people out there that are on them. And much of the reason why someone will be on them long term is because they just can't come off them because they were prescribed them years and years ago, and it's just so difficult to come off them.
And that's my thing. My thing is that with those particular drugs, my goal is to not get anyone new
on them. Yeah.
Now, they are, for what they're meant for, they're great drugs. Like, they work incredibly well in short bursts for what they're designed for, but they're not a solution.
No. I want to touch on grief before we end up, and males dealing with grief, because I think that we're not dealing with grief, burying it, because I think that, even speaking to relations of mine, they would have said, when a family member died, the women in the family would be gabbling amongst each other. They'd be crying, they'd be wailing, they'd be able to talk about that person, whereas the men retreat into themselves and often go through a very dark patch themselves.
And they don't acknowledge the impact that it has on their, it's like, but sure, why would I be sad? I didn't die.
Yes.
Do you know?
Yeah.
It's like, because someone did. And secondarily, it forces you to confront your own mortality, which is something I don't recommend any of us do on a regular basis. But it's back to the strong, silent man stereotype. It's like, no, you can't be talking about your feeling.
Yeah.
Do you know? I think you mean feelings. No, it's just the one of them. But it is, so, like, the interesting thing is that a lot of the research on grief doesn't really go into the gender of the people involved.
I know.
Which I always think is a bit telling. It makes me very skeptical that they have a good balance of genders in those study populations. If they're not talking about it, it's what are they not talking about? But men have a tendency to grieve quietly and on their own and very introspectively. And it can be very unhealthy.
Yeah.
I'm not saying that you need to go and start gossiping with everyone and telling everyone and never talking about anything else other than your grief. But you do need to acknowledge that it's happening and that it's real. And if you're not the type of person that's comfortable living in that grief, so talking about it continuously, talk about it. Find friends or family who you can talk to. Tell them what you're feeling. Tell them, look, I'm just going to say this if that's okay. I don't need you to fix it.
Yeah.
And I don't need you to tell me what to do.
Men tend to want to fix things themselves, don't they?
Yeah.
I know going to a man with a problem, they're like, I'll fix it. I'm like, I just want to vent. Will you leave me be?
I'm dreadful for that. I'm really awful with trying to solve everything that my wife says to me. And it's just like, we're just having a conversation.
I know.
It's like, sorry. But it is. And it like, that's a really bad thing to do, to try and always fix it. And one of the big things particularly with emotional stuff, you don't know enough about that person to try and fix their emotions.
Yeah.
No matter how well you know them.
Yeah.
You don't know what's going on inside their head, but you can be there and you can listen. And what you need to do is, some men, I think, don't particularly like to talk about it because they do worry that they are then, well, the next time I see John, is all he's going to be thinking about is, Jesus, he's still very cut up about such and such.
Yeah.
And a lot of the times that's an unfounded fear. Like, you'll chat to them and then the next time you meet them, they'll take the piss out of you again.
Yeah.
Do you know?
Yeah.
It is one of those things that, like, it's okay to acknowledge that you are not doing okay. And then it's equally okay the next time you meet that person to not want to talk about it.
Exactly.
Do you know? You don't have to be, that doesn't have to define who you are.
No.
But I think acknowledging that grief is there and that it goes on for a long time, particularly I see it a lot in men who've lost their wives after being married for decades.
Yeah.
And they go, when will I feel okay again?
Oh.
And it's like, how do you answer that?
Yeah.
Like, you spent 50 years with this person.
Yeah.
You're never going to feel the same. But it gets, from what I've seen, and it's one of the privileges of being a general practitioner, is you get to see people over extended periods of time. You get to know them and be part of their life in a way. And you see, it becomes less raw. Is all I say to people. It's like, you'll never not miss her, him.
Yeah, of course.
But it won't be crippling. I read once on Reddit of all places, which is not usually a font of wisdom. There was a guy who put up this this really good analogy of grief as being on a survivor of a shipwreck, and you're clinging on to, it's in a storm, you're clinging on to a floating piece of debris, and the waves are washing over your head continuously. And then over time, the weather calms down a bit, and the waves are still washing over you, but you have a chance to catch your breath between them.
That's a good analogy for Reddit.
It is. Yeah, as I said, it's not where I expect to find wisdom. But it was one of these things. And then he goes, and it'll catch you. You'll still get a wave that you don't see coming. Like it'll be a Tuesday, or something will happen, and you'll say, "Oh, do you know who'd love to hear about?"
Oh yeah.
And it'll catch you, but it'll be less.
Yeah.
And so I think it's important to acknowledge that you are grieving.
Yeah.
But
and
also
that goes for relationships too. When relationships break up, and it's almost like, the women are allowed to wallow with the men. Oh, go and find another girlfriend.
Yeah. I'm free now again. Is the
go back out on Tinder now. Yeah. So I think that it's important that males
but like grief over other things. Like I think the death of someone, I feel that we as a society rate whether people are allowed to grieve or not.
I know.
It's like someone died. Yeah, no, you can grieve for that. It's like, I got dumped. How long were you going out with them? And more importantly, did I like them?
Yeah.
I didn't really. So you're better off.
Yeah.
I don't really care how you felt about them.
Yeah.
And then it's like, my dog died. And that's a funny one, because if you go and talk to someone who is a dog person, it's like, oh, are you all right?
Yeah.
You talk to someone who doesn't have pets, it's like, and?
Yeah.
So I think grief is something that we should accept at face value. It's like, if you tell me you're upset, you're upset. Whether I think you should be or not really is irrelevant. To find a decent friend.
I'll keep it to myself.
Yeah.
And then, so just to touch on the fertility thing as well, when a couple are struggling with fertility, it's usually the female that's the focal point. If they are being vocal about it, or if they've had a miscarriage, it's usually the female that is given all, is wrapped up, is loved, and the male can often feel like an outsider, even though he's very much a part of it, particularly if it's miscarriage. And I think that what you've just said about grief is really important, that the male does acknowledge his role in it, and the fact that it was also his baby, and it was very much a part of him.
I think men get forgotten in miscarriage all of the time.
Yeah.
Because it didn't happen physically to them. But yeah, as you said, it was their potential child as well. It is. And I think they often feel, well, no, sure, it didn't happen to me, so I can't draw attention to me. That's selfish.
Yeah.
I need to look after her.
Yeah.
And that's great. It's laudable. But like, you can do both.
Yeah.
You can be nice to your partner and feel a bit sad.
Yeah.
We're capable of holding two emotions at once a lot of the time.
Even men.
Yeah. I can be hungry and tired.
That's really surprising.
They're my two emotions. But yeah, no, it is. It's one of these things that, like, accept that you're sad, be sad, and be okay with being sad one day and not the next.
Yeah.
Like, it's you don't have to be continuous. I don't know. Like,
yeah, and there's no rating. It's not a case
not a competition.
of, yeah, exactly.
You know?
Exactly. Phil, I could speak to you all day because there's loads of issues now. I'm going to bring you back. We'll delve we'll delve into more and more discussion. But we like
talking.
Yeah, but we had a really good general discussion. I think we answered loads of people's questions. But I have two questions for you that I ask everyone before we wrap up a podcast, and it is: what is the meaning of life, and what advice would you give to young people today?
So, yeah, they're nice, easy ones, aren't they?
Oh yeah, I deliberately, make them real easy.
Make them easy.
Yeah, so you don't have to procrastinate over them.
Is 42? No, 42 is the answer to life, the universe, and everything. Advice to young people: do you know what I would say is find friends that you like, okay, and that like you, and that don't have too much demands on you and you on them, right? Because you always hear people. Someone says, "Oh, I have hundreds of friends," and it's like, yeah, but do you like it? Like, I have about 5 good friends. That's plenty. Do you know?
Yeah.
So find people, be careful who you surround yourself with, I guess, is what I'm saying. Which is, I don't consider myself any sort of expert on life, on advice to young people. Try and survive being young. It gets easier.
Yeah.
what is the answer to life, or what's the meaning of life? I don't know. Contentment. I think a lot of people worry about being happy all of the time. I would forego happiness forever if I could have a lifetime of contentment.
Yeah.
Do you know? It's less tiring than being happy all of the time.
Yeah. It's too much effort.
It's too much effort. But that's it. Like, you shouldn't aim for bliss continuously. And I think social media can make you think that that's what everyone else has.
Well, I don't think we were put on this
Everything
earth to
should
be
just be
blissful.
okay.
Yes. Yeah.
That's what you should be shooting for.
Well, that's lovely. And thank you very much.
Thank you.
It's been wonderful having you. Thank you.